Hi, folks, and welcome. We are just letting everyone come in and get settled, so we will get started at the top of the hour. But again, thank you for joining us. Okay, folks, welcome to our second webinar, Connecting Human Factors and Ergonomics Theory with Applications in Healthcare. Today's topic is physical ergonomics and exoskeletons in surgery, and this webinar is co-hosted by the Human Factors Transforming Healthcare Network, the Human Factors Healthcare Technical Group, and we have a special guest, the Society of Surgical Ergonomics. So welcome. Right, so a little bit about the series as if this is your first time joining us. This was really a series that was developed and be on the lookout for ones next year, but it's really about connecting the theory of human factors and ergonomics to practical applications, and we're really centering this work in healthcare. And this is meant to be inclusive for anyone and everyone working within the healthcare space. We hope that students find this valuable from the perspective of getting a broader understanding of different types of work that are occurring, maybe picking up a thesis or dissertation topic out there, and maybe even connecting with folks both in the practical applied setting or in the academic or applied research setting, and areas that perk your interest. For researchers, hopefully this will also be value added to help, initiate maybe new connections, new collaborations, or just help you identify a new research topic. Practitioners, I myself am finding this incredibly valuable because as a practitioner, I feel as though I have a bookmarking and download problem where I see amazing work coming out and I get really excited to read all the new research out there and I download it and I bookmark it and then I just never seem to have the time to go back and read it. So this is like my own personal way to really get an understanding of the really amazing work that's coming out, and how I can look at ways that I can apply it in the work that I'm doing. Leaders and patient safety teammates, quality teammates, anyone within the healthcare sphere, hopefully this is value added for you to understand how human factors and ergonomics can really improve healthcare, and the work that we're doing. So I am Dr. Brittany Anderson Montoya. I am one of your moderators for today, and I'm going to kick it over to Dave.
Hi, I'm Dave Nyans. I am the co-moderator. I'm representing the HFES Healthcare Technical Group, and Brittany is representing the FHTH group as we co-moderate the webinar today. So we want to welcome everyone. Thank you for attending, and we look forward to a great presentations and discussions. If you have questions throughout the presentations today, at the bottom of your screen, there is a Q&A button. You can type in a question that you have for our speakers that they can potentially, co-speakers can help answer questions, or Brittany and I will collect them and help facilitate getting those questions answered at the end of the webinar for everyone. So welcome. I'll give it back to you, Brittany.
Phenomenal. And what you're all here for today, it is my extreme pleasure to welcome our speakers, Dr. Susan Hallbeck, Dr. Jackie Cha, and Dr. Philip Haig. All right, without further ado, I am kicking this over to our speakers, and I look forward to a phenomenal webinar and some good discussion after. Thank you.
Hi there, everybody. Let me just share my screen and we will get started. So I'm Dr. Philip Haig. I'm an oncologic and endocrine surgeon here at Kaiser Permanente in Los Angeles at the Los Angeles Medical Center. It's very close to the Hollywood sign. I'm also representing the Society of Surgical Ergonomics as the president of the society for this year. So thanks also to HFES for having us, the technical group and the other acronym that I might not get right. So, but thanks very much for having the Society of Surgical Ergonomics participate. Uh, it's delightful to be here today. So let's get on with it. So is the problem is this. So this is what I felt about 12 years ago. I was operating, I was doing a thyroidectomy, and I remember the day vividly. I remember the resident. I kind of forgot to tilt the table back the other way, and I went around the table to do the other side of the thyroid surgery, and had absolute sudden excruciating pain in the back of my neck. I'm not kidding you. It felt like a Bowie knife in the back of my neck or a Game of Thrones and Targaryen steel in the back of my neck. And so that acute pain, it subsided over a few days, but it turned into chronic neck pain, and I tried absolutely everything for it. Including acupuncture even, and it didn't disappear. So I have it to this day, 12 years later, but obviously it is much milder. But this pain is actually very prevalent in surgeons, and it has to do, at least the neck part of it, the neck pain. I'm not talking about back pain or anything else, but that's coming up. It's to do with this craniovertebral angle, and if it's really low or less than 50 degrees, we constantly have our forward head posture craning. I mean, the size of a thyroidectomy incision is only about 5 centimeters. So to look through that needs some neck craning. So if you look at me here on the right, my craniovertebral angle is about 10 degrees. I think my resident across from me is almost the same. And that's, I do 3 of those a day, perhaps, twice, 2 days a week. So it just adds up in that forward head posture chronically. And there's other fixed postures. On the left, actually, is a colleague of mine, and her craniovertebral angle, I think, is 0 or even negative, actually. And that's her doing a Whipple operation, a pancreaticoduodenectomy, which takes around 4 to 6 hours. So that's a tough one. And then there's other on the top right, the contorted fixed postures. Almost, I mean, that one surgeon on the top right is all anymore, and that person's going to be doing a somersault. And then the bottom right's a vaginal operation, and there's tape on the lead surgeon just to show that her back is not a nice vertical posture, and then her assistants are also twisted and turned in a fixed bad posture. So there's quite a bit of data now on how prevalent it is. It's very prevalent. A meta-analysis of 41 articles with 5,000 plus surgeons, many surgeons reporting pain and fatigue and numbness and stiffness, especially in the top sort of body part offenders is the neck and the low back, but also the shoulder, and less so the arm. And would you believe it? I was shocked to find out that surgeons actually have higher musculoskeletal pain uh, than apprentice construction workers, far exceeding those folks. And I'm just shocked to think that if you're hauling lumber and drilling up with a, up to the ceiling, that they have less pain than surgeons do. And actually, notably, residents have pain, and we should really stop and think about that. Surgical residents, the average age is, I think, 26 for residents. They actually have pain, and that did we ever talk about? Do we ever talk about? Did we ever talk about it when I was a resident back in the day? Absolutely not. This was never brought up. But every specialty, orthopedics, urology, OB-GYN, general surgery, plastics, uh, all report high rates of pain. And this is just a study. It's sort of in manuscript preparation mode. Um, but I did this a sort of a survey study, but it's also linked to the cases that were done. But I sent surveys to 29 surgeons every day, every evening for 30 days. And that on the right is just the text that we get. And even as the PI, I can tell you getting getting the 28th survey, it's like, oh, come on, do I really have to fill it out? But many surgeons filled it out for 30 days, and I really wanted to control for daily life. And so I sent it on, Fridays, Saturdays, Sundays as well. So there's 228 operative days, 214 clinic days, and then 299 sort of administrative days or off work days, like a Sunday not doing any work in terms of surgical work. And lo and behold, when I compared pain after an operative day versus a clinic day or an administrative day or an off work day, for every body part measured, which was 12 body parts, 12 body regions, there was an increase in the pain score compared to those off work days and clinic days. So the big offenders, again, neck pain had sort of the highest pain scores, shoulder, and then upper back and low back. And this was adjusted for the surgeon's age, their sex, their BMI, and the amount of exercise they did, moderate to vigorous exercise hours per week. And then Dr. Hallbeck, who's with us today, this is a paper of hers showing that with 53 surgeons using wearable posture recorders, 12 surgical specialties, surgeons assume this high posture risk, 65%, and the neck is in a high risk position. And the torso less, but 31% is in high risk. And then the shoulder is 11%. So what can we do? So there's some low-hanging fruit, but I kind of want to jump to some outside the box things, and it gets to what the topic of this webinar is all about. This is actually an $850,000 piece of equipment, an operating microscope. And normally, usually general surgeons like me, surgical oncologists like me, endocrine surgeons like me do not use this. But because of my musculoskeletal issues, I actually started to use it, and I could get out of that high risk posture to more of a, the craniovertebral angle that's actually reasonable. So we can do things like that. And that actually was, a neurosurgeon said to me, hey, have you considered using the operating microscope? And I said, I have no idea what you're talking about. So I Googled it, and it was described about 10 years ago in thyroid surgery, but it was really just to look at the recurrent laryngeal nerve, sort of a specific part of the operation. And anyway, I tried it out, and the learning curve was very quick, but I used that. Another possibility is exoscopes. I actually don't have a lot of experience with using these exoscopes, but it's a camera system, and basically you point it at the incision, but you do look up at a screen. So on the left is the device, and then you can look at the monitor. I must say that the monitor is too high for these surgeons. They need to lower that monitor. You see their neck's a little bit too high, but it actually there's some data showing that it perhaps helps in some situations. And this is also a study from Mayo Clinic looking at a DF flap, which is a reconstruction after a mastectomy operation. And there's an abdominal portion, and then on the actual chest portion. But in some cases, this exoscope reduced the high risk postures in the neck and the torso. It actually made it worse, perhaps, for the upper arm. But there does seem to be promise with exoscopes and avoiding those high risk postures. And then we get to the topic of today, exoskeletons. So I use this. It's called the neck spine device. And more to come on this towards the later part of this webinar, but I'll now switch to Dr. Jackie Cha, who will take over. Dr. Cha.
Okay, thank you, Dr. Haig. Let me share my screen. Okay, everyone can see. Okay, perfect. So thank you for the quick transition. So I'm Jackie Cha. I'm the Patty Brennan Assistant Professor in Industrial and Systems Engineering at University of Wisconsin-Madison. So a lot of my work is really trying to understand the ergonomics in healthcare and in surgical settings. And so I wanted to really now transition into, well, we heard the physician and the clinician perspective. So what are we as ergonomists and human factors engineers really trying to look at, and how do we look at these pains that they're all facing? And so Dr. Haig did outline a couple of statistics in terms of the pains that surgeons are really experiencing in their neck, their shoulders, and lower back. But I also wanted to make sure that we also talk about everybody else in the operating room. So things are people like operating room nurses. So these are usually the nurses, and these are the folks who are responsible for moving patients, preparing the operating room, interacting with the sterile field. These folks have reported pain in their lower backs, as well as you can see an image on the here where you see a nurse who is she's actually smaller than 5 foot, and she's trying to hold a larger patient's arm up as they are actually preparing their different type of vitals. And so when you have that, it's almost like a posture that you might actually see in an industrial setting, right? It's overhead work almost for her. Also then thinking about surgical technicians, these are the folks who are going to be right next to the surgeons as they are preparing or completing surgery. They're responsible again for that preparation in the operating room, surgical assistants, transporting equipment carts. And these folks have also reported pain in their lower backs and shoulders as well. And then another group that we might actually often overlook, but in terms of the scope of the projects that we were looking at, we actually included central processing technicians. And so these are usually the folks who are actually going to be sterilizing and packaging surgical instruments. In the hospital that we were collaborating with, the surgical technicians actually took a shift in that central processing core. And so we actually wanted to make sure and highlight that we are also looking at those type of job tasks as they are performing them, as well as then thinking about, well, in other hospitals, if there is a unique surgical team that is going to be looking at, or just a team in general, this type of task, that we do also consider them as well. And so we do see that for these folks, they also report pain in their neck, lower back, as well as shoulders. So in terms of the literature and what we're seeing that is going to be published, there's a general call and an understanding of ergonomic principles, problems, and potential solutions in the operating room. We see that there's more and more systematic reviews, meta-analyses, really considering and highlighting that this is a problem for the surgical team population, as then while, of course, thinking about different types of interventions. And so to highlight a couple, and again, Phil actually mentioned a few, but thinking about how do we actually change the work environment? How do we actually think about different type of technologies or the processes that we actually handle different type of surgical tasks? So do we use tilted tables, looking at slide boards to reduce physical demands during patient transfers, for example? Thinking about training, are there ergonomic trainings that we can actually inform individuals and folks, these are the best practices, or these are the best ways that you might move when you are handling this type of task? Or are there different type of supportive technologies? So we're going to be talking about exoskeletons in this webinar, but thinking about the exoscope or a robotic camera holder that can actually provide different type of support than maybe a human will have to hold isometric or isostatic postures for a long time just to hold a camera, for example. So thinking about how do we actually consider different types of ways that we can help support individuals. I also wanted to highlight here that there are, again, different types of training. So thinking about how do we actually inform the individuals as well as the team members, what are those best practices? There's ergonomics workshops that have been published, and folks at Mayo Clinic have looked at and have presented on, well, here are the best practices. These are the ways that you should actually be holding yourself in the operating room so that you do have better postures. And then this is not only for open surgery, but then also thinking about laparoscopic surgery as well as robotic surgery. So I think a lot of folks think about, well, what are the best ways, but then also acknowledging and looking at what are the actual poor postures as well. So those are the images that you see on the left, where there are publications and there are studies that are showing, well, these are actually bad practices and these are improper ergonomic principles that are being applied in the operating room. And so how do we actually make it so that they are actually more compliant, so that they actually do have less pain and injury? So highlighting that there are different ways and approaches to really understand and help support these workers. But then thinking again about how do we actually support the surgical team as well as doing the surgery. And I think this really highlights the way that we as ergonomists and human factors engineers really collaborate with surgeons and surgical team members. So Dr. Haig and all of the MDs and all of the nurses, they all know the work and they are actually the workers doing the work. And we as human factors engineers really are trying to understand, well, how can we actually help improve that, right? So it does become a partnership of we are bringing in the tools to actually help analyze, understand, and assess everything that is going on, and then help them actually perform their work better. So here really highlights the paradigm that my lab is actually thinking about in terms of how do we use different type of technologies. So first, we need to really understand the user needs as well as the technology needs. Maybe it is that an exoskeleton may or might not work. Maybe they need an exoscope rather than an exoskeleton. What do the users actually need as they're performing a specific task? And then when we're thinking about that intervention, well, how effective is it? And is it actually usable for their platforms and for the work that they're doing? How do we actually train them so that they are using the interventions in an effective way? And then, of course, integrating them into the existing workflow. So here you see a series of photos where we did do observations in the operating room, really trying to understand, well, what are the worker and user needs? How do we actually simulate that in a laboratory so that we can actually have very systematic evaluations to assess this technology? And then thinking about how might we implement it? And then thinking again, it's not only about the surgeons, but it's about the surgical team. So engaging everyone in the early end so that we actually can understand what they might need. And so I want to highlight just a series of experiments that we did in the laboratory to really understand if exoskeletons can be effective in minimizing their musculoskeletal disorders and pain. And then I want to actually have a caveat here. We're actually going to be talking about passive exoskeletons. There's a whole body of literature and different applications for active exoskeletons, which are going to be more of the exoskeletons that have electrical components. And so I don't think any of us are talking about those. And then also there's different types of exoskeletons that might support your upper body as well as your lower body. And these are things like your invisible chairs, for example. And so there are all of these different type of applications, but the big thing that we wanted to understand is, well, us as engineers and HF folks, we know the technology. So we know what kind of technology might actually help support the folks as they're completing their work. And so that's why we, at least for our studies, did not look at the other types of interventions in terms of the exoskeletons. But then thinking about here, we actually did a study where we actually systematically evaluated a series of postures that occur in the operating room. So we actually held different type of postures in place in terms of their shoulder angle combinations, of their flexion and abduction angles, to really understand, well, if somebody's doing a laparoscopic surgery, these are the type of angles that we've seen. And so what happens if it actually, an exoskeleton is worn and it does muscle activity actually get lower? And so we also did different type of series of trunk flexion as well as symmetric as well as asymmetric rotations, which I won't be presenting here today. But thinking about, well, how did we actually develop the study? Of course, we did it in the laboratory. Thinking about what are the simulated laparoscopic tasks that people can be doing. We actually had folks set with a gynomotor, thinking about where's the actual posture, and then have them maintain that posture for the duration of the entire task. We actually evaluated 2 shoulder support exoskeletons. So we looked at the Hapo front and the Auto back Paxo. So in terms of this way, we also wanted to evaluate, well, what kind of technology might be actually helpful for the tasks that we're looking at. At first, we were only looking at the exoskeleton on the right, but then we were introduced to the exoskeleton on the left, and we saw that, well, maybe they actually can support different postures that the one on the right cannot, right? So thinking about the actual mechanism of the device, we actually saw that, well, maybe the Hapo front will support and engage in postures that are at lower angles that surgeons might actually be at, rather than the one for the auto back. And so that's why we decided to test these 2. We, of course, had a control condition that folks had no exoskeletons worn as they're completing the tasks. And then how did we evaluate, right? So thinking about surface EMG, so muscle activity, we follow best practices to get all of the normalized data. And so thinking about how can we actually have these comparisons and statistics to draw conclusions, we did the comparisons between control, which is actually the table that you see, or the row that you see in the middle here, and then the Hapo on the left, and then the Paxil shoulder on the right. So looking at this figure, you see the different combinations of the flexion and abduction angles that we were looking at, and then the differences from the control muscle activity measures with the Hapo as well as the Paxo. So the biggest way, or the easiest way to interpret this figure is, do you see more green or do you see more red? So for this, you actually are looking at the results of the left anterior deltoid, and the left anterior deltoid is responsible more for shoulder flexion. And so here we actually see that the Hapo provided more support in their lower angles, and the Paxo actually helped support in their high angles. And so thinking about, again, the mechanisms of these actual devices, it actually is that the support might actually be more helpful with the Hapo because there's additional support on more of your lower than your elbows, technically, and then thinking about the Paxo actually engaging at a higher angle. And then thinking about more about left medial deltoid, this is actually the muscle that is responsible for abduction. So here you actually see the difference between the green and the red. We see that the Hapo actually helped in the reductions of muscle activity throughout the various combinations of postures, but we actually saw that the Paxo significantly increased the muscle activity across different postures compared to the actual control conditions. So thinking about how do we systematically evaluate and think if these devices will be helpful in the operating room. A big caveat with the study, the tasks were shorter in duration, as well as you actually see the general muscle activity, even in the control condition. So this is the condition that folks are doing the laparoscopic simulated tasks in without an exoskeleton. They're actually quite low. You actually see values that are less than 10% muscle activity or normalized muscle activity. And so we see, well, what does that really mean in terms of a 1% or a 2% decrease or an increase of muscle activity from that lower value as well? So these are questions that we're continuously thinking about, and if they will actually be an accumulation or a helpful intervention in the long run. And then, of course, thinking about, well, again, the rest of the surgical team members, we do very similar studies thinking about, well, how do we actually evaluate systematically of the different types of tasks that they're doing? And so we see that for surgical team members, we see that generally that the shoulder support exoskeleton can help in holding tasks or in static holding tasks, which are actually often completed by the surgical teams, especially by technicians. So this might actually be an intervention that might be helpful for those folks. And so with that, I will actually end here and give it off to Dr. Hopek.
Thank you, Jackie. That was really interesting. And I want to note that she has done both work that is in the simulation center, but also in the operating room. And I have primarily done things in the operating room. Because I'm at the Mayo Clinic, I'm the scientific director for human factors engineering in the Kern Center in the Science of Healthcare Delivery research at the Mayo Clinic. And I'm a previous Human Factors and Ergonomics Society president and a previous Society of Surgical Ergonomics president. And so my laboratory is actually the operating room. And I depend on people like Dr. Cha to do some of the vetting for some of these exoskeletons and other interventions for me to take into the OR. But I first want to start out and say, surgical ergonomics isn't new. Over 100 years ago, one of the forefather and mothers of industrial engineering, the Gilbrists, had their children, and they all had their tonsils out at the same time in their kitchen. And they determined with video analysis that they needed to have a scrub tech, the scrub technician that Jackie talked about. And they then would put them on a Mayo stand. And this started the entire work team for ergonomics. That's not what we're here for today. We just want to make sure that we know that this has been around for a while, and we just still need to do something with it, because over 100 years ago, in the operating room, you can see what the operations looked like. They had really thick gloves, and they had their nose outside of their masks, but they still had a bad posture. 65 years ago, they still had bad posture. This happens to be one of the first heart-lung machine surgeries. And look at that posture that the surgeon has assumed. We have more technology in the background. And then today, there's still bad posture. Lots more technology. So the cognitive load has gone up and the physical load has not reduced. So operating is stressful. You saw some of the pictures that Phil had, one of the pictures, the bottom center, but these are all representative of different types of cases: sitting, seated, standing, bending, twisting in awkward positions, often due to things like on the upper left, the addition to the glasses is called a loop. And that is a magnifying glass attached to glasses, and then the headlights. So you need to light the surgical field and see into it. So we talked about some methods, and Jackie started with some. We often do mixed methods studies. We have things like NASA task load index, which has been adapted to a surgical task load index. We talk about degree of difficulty of the surgery. We use the Nordic questionnaire, which has been around for 40 years. And we've more recently added survey instruments for things like burnout. We use the RULA, the Rapid Upper Limb Assessment, the REBA, the Rapid Entire Body Assessment, and other observational metrics. And then we pair that with things like objective measures. So if we could, we'd go into the motion analysis lab. You can see the surgeon over here testing out some new equipment with the reflective balls. And we then validated some inertial measurement units, IMUs, during that case. And we then use those wearable sensors in the operating room. We can use those for the posture. We can use that for stress, using heart rate variability or galvanic skin response. And then we can also use things like real-time location services if we have the right availability. Some people are doing some video analysis. Jackie has done surface electromyography, and then we can always use things like performance metrics of time and errors. So we have both subjective and objective measures. But today we're talking about exoskeletons. And one of the questions that was posed is, how do you pick an exoskeleton? Jackie started out by saying that we look at what the need is. So we need to assess the different exoskeletons that are on the market. And so for me, I went to the Human Factors and Ergonomics Society's ErgoX conference on exoskeletons. And it was really nice because they had a bunch of vendors who were there for us to try on different exoskeletons. And I'd already come with my wish list. And based on the surveys that we've done, the neck and the back are the two highest painful areas for surgeons during surveys. But when we looked at our data also for the duration of surgeries that had awkward or very awkward positions, again, neck was the highest, then the back, then the arm. And then there's some people who want as Jackie talked about, the sit-stand type exoskeleton. And so let's determine that area of support that we want to find. And then we need to pick between two types of exoskeletons, the passive exoskeleton and the active exoskeleton. The difference there is the active exoskeleton is actually powered and will move you rather than just supporting with something like a rubber band or some gearing, or in the case of a later study, we're going to look at carbon fiber mass that you are against. And so I think that one of the things we need to discuss is some of the um, the limitations of being in the operating room. When we talked to the leadership of the operating room, they said, no active exoskeletons on the surgeon or the surgical team, because if that fails during surgery, we have a patient safety issue on our hands. And so you can have passive ones, but not active ones. So for us, then we just go with the passive. And then we need to determine if each of these exoskeletons will meet the sterility challenges in the OR. So it has to fit under the gown. When you saw Dr. Cha talking about the HOPO, it had those rods that bend over, and they attach just above the elbow and hold up your arms, and they are also on a waistband. Those, even though they looked like they curved up pretty high, did fit under the gown. We have to avoid the sterile zone, which is from the elbow all the way to the tip of the finger, and then basically from the armpits to the surface level of the patient. And things can't really go above the head. And any controls on an exoskeleton that falls within that sterility zone need to be able to be done by the surgeon, by themselves, or if it does not, they can be done by the staff. Things like on the head, on the shoulders, on the back. And we try to ensure that there's been lab testing, and I depend on Jackie a lot for this, to look at what exoskeletons she's looked at in the lab prior to us bringing it into the operating room. And then we need to assess whether it's acceptable to the surgeon and the surgical team in the operating room. And so again, building on what Dr. Cha has done, we came up with an exoskeleton introduction. First, we got all the correct OR approvals. We needed to get the surgical services, the nurses, the Department of Surgery, chair, a whole level of people, contact the infection control people to make sure that everything works, and they will allow us to go in. Then we try to identify a surgeon champion for each of the different specialties we want to go in. And they help us recruit their colleagues, their partners. And so then we often meet with the surgeons. We always meet with the surgeons one-on-one, often in their office. And so we have them test out the exoskeleton to see if they think it might be useful and acceptable to them. And there have been people who put it on and said, no, count me out. In fact, that happened on Wednesday when we went over to one of the health system places. They said, I'm not all over this one. I'll try this one, but not this other one. And so then we want to determine the surgical procedures that are most impacted. And we often ask them, the surgeon or the staff, to say, where is the one that you're hurting? And is it in your neck? Is it in your back? Where are you hurting? And often then they will simulate postures from these procedures because they know what they adopt and they know how they feel when they come out of the operating room. So then we try to test it out either in the simulation case like Dr. Cha, or we go into a very short case to see that there's not anything that's going to cause a problem in their longer clinical cases. And so we also are there for the first few clinical cases, especially to help them put it on and take it off, which is called donning and doffing, or to adjust it, final adjustments before they go in, final adjustments as they go through their case, because what feels good outside the OR may need a little bit of adjustment within the OR, and the staff is not necessarily comfortable doing that on the first round. Or if there's an issue, to be able to remove it during the procedure. And that has not happened to us, but they like us being there just in case. We have trialed 2 different back exoskeletons. One is a more rigid exoskeleton. You can see where's my cursor? The struts here, and it leverages, and you feel it against your sternum here, and it leverages against your upper thighs. And this one, these rails started to interact a little bit with the bedside, and it didn't have an onset early enough to really get the load off of the surgeon. And then we tried this one, which is more of an exosuit. It's a soft versus rigid, and it has rubber bands and a thigh strap. And this one you can see right here is the control. It's a little bit outside of the sterile zone. We got an exemption for that because it could be under the drape and the surgeon could actuate that and have it holding them up or release it with this little button here by themselves really easily. But the issue is that both of these are industrial exoskeletons. And so they're looking for people who are picking up boxes from the floor. What we're looking at is a 30 or 40 degree forward bend. And we want to have an onset of about 10 or 15 degrees forward bend. And so the surgeon then has to lean back and actuate it. And that's difficult to do and get right the first time. And you don't really have a way to adjust it during the case. And so we found mixed results with this one, or these two, sorry, for the back. Then we tried to look at a neck exoskeleton because we knew that there was the highest priority was to take care of the neck. And we had initially tried one from a different company that was a prototype, but the mass went very high and hit the light in the operating room. You can see that this is the light edge of the light right here. And why would we start with the neck exoskeleton? Because 50 to 60 to 70% of surgeons have neck-related, work-related pain. And so we did a study where we wanted to evaluate the effectiveness of an intraoperative exoskeleton for the neck, which also supported the back. And the device we tried was the neck spine. And here are the three things that we wanted to determine. We wanted to see if it decreased discomfort, if it mitigated extreme postures, and it did not interfere with performance. And so let's start out with the mitigating extreme postures. So we wanted to limit the amount of time that they spent in the awkward and very awkward postures, those that are high risk, the orange and the red that Phil showed you earlier. So we had 12 surgeons do 4 surgeries each. They were paired by case. So you had one baseline case and one neck exoskeleton case. And so if you were, say, a breast surgeon, you would do maybe a skin-sparing mastectomy pair and then a nipple-sparing mastectomy pair. Although most of them did nipple-sparing mastectomies because that's the one where they hurt. We would then pair those by the duration of the case, and if they had 4 of the same, and then we use student t-tests to evaluate. We had these 12 surgeons. We tried to get 6 and 6, but we got 7 and 5, which is pretty good based on the demographics of surgery. All were right-handed. They represented breast surgery, cardiovascular, plastic surgery, thoracic surgery, urogynecology, and vascular. Each did their 4 cases, and the median duration was almost 3 hours, and the IQR was between an hour and 5 hours. Here's the metrics that we used for this study. We used the NASA TLX, the task load index, for workload, for mental demand, physical demand, time demand, their perceived performance, the effort that they put in, and their frustration. We also did a discomfort and fatigue survey. So we looked for the discomfort in the neck, left right shoulder, left right upper arm, left right wrist and hand, the upper back, the lower back, and then we had an overall fatigue. So we had them do that at the beginning and at the end of the case. And then throughout the case, we got the inertial measurement units and we got their neck angle and torso angle, right and left upper arm angle. Again, can't put anything from the elbow down to the tip of the fingers. And then we classified that in the percent duration of surgery in those risky postures. And that was that 1 to 4, where we're really concerned about the orange one and the red one, the 3 and 4, the levels 3 and 4. And so here is that same diagram. We're concerned about 3 and 4. Here's the placement that we had for the inertial measurement units. And that is the measurement unit itself. We use the APDM IMUs, and it's referenced to a quarter. Here are the usability questions that we had, only for those with the neck exoskeleton. We wanted to know if it interfered with their ability to perform surgery. Did it improve their ability to perform surgery? Did it impact their range of motion? Were you more comfortable? Would you use it again? Did it interfere with the workflow? And did it, or your surgical equipment or the work of your colleagues? So let's start with the changes in discomfort. So the exoskeleton is in blue and the baseline is in the red stripe. So if we look at that, the change in discomfort is higher for the baseline. It is reduced in the exoskeleton case. The best case scenario is here, where it actually improved for the left and right shoulder, as well as the left upper arm, their baseline, or I'm sorry, their discomfort. So it actually was less uncomfortable than when they started the case. And you can see that it also, so it was statistically significant for the neck, but it also was better for the low back, upper back, and reduced fatigue, but not statistically significantly so. Then let's look at the angle of the neck versus the torso right arm and left arm. We had a statistically significant reduction in that neck angle. It went from 34 down to 28. And that was statistically significant. Now, one of the things that we were concerned about initially was if you reduce the neck angle, are they then going to move their torso further? And the answer is no, they did not. It was not statistically significant, but it appears that the exoskeleton for the neck also reduced the angle of bending at the torso. So that was a really positive thing for us. And so if we look at this overall with our 12 surgeons and their 2 matched case pairs, we went from the dark circle here, which is the baseline, to the stripy circles, which is the exoskeleton. We reduced statistically significantly the duration of the case, that then they were in that highest risk. It really didn't change the risky, but it increased the lower risk in a positive way for both the neck and the torso. In the usability, they for the most part, they wanted to use it in future cases. One man and one woman said maybe, which was not one of our answers. After the first one, they were not sure, and that was due to a little bit of lack of setting it up as well as we could have. So on the second one, we did a little bit more fitting with them, and it worked out great. And then the exoskeleton did not interfere with the workload. Again, those 2 same people, it interfered a little bit because we had not set it up as well as we could have. Did it interfere with the surgical equipment or colleagues? We missed one question on one of the 2 batch pairs. So we missed that for a single case. With every study, there's limitations. We only had 12 surgeons. It was over a number of surgical specialties and a number of different procedures. And because it is something you wear, we were unable to have a randomized blinded control trial. So what did we start out with? We wanted to decrease discomfort, mitigate extreme postures, and not interfere with performance. We found that we did decrease discomfort, we did mitigate extreme postures, and we did not interfere with performance. So we think that we can say that the neck spine, shown here in plastic surgery with the autologous breast reconstruction, breast surgery, it appears to be an intervention that can reduce discomfort and extreme angles in the neck. That reduces the pain and hopefully will protect the surgeon's quality of life and prolong careers. And this is written up in the Annals of Surgery for anyone who wants to go and download it. Phil?
All right, let me share my screen. All right, so I mean that's fascinating, Sue. Every time I hear a talk from Sue Hallbeck, I mean I'm kind of just blown away. We work in our silos and we don't hear much about this at all, and to see all this research and progress is amazing. And what Jackie Cha does it's so helpful for us. So the diagram here, I just want to go through this slide and then I'm gonna actually show the device on my my camera. So I've actually worn the neck spine now for about 2 years. So uh, actually Sue Hallbeck told me about this device. I didn't have any idea about it. And then I contacted the company and the rep came and he actually showed it to a bunch of surgeons in the OR lounge and he came to my office on another setting. And so I tried it in the office and immediately I just thought, wow, this is incredible. It just really supports your neck. So the device is three parts. It's a vest. So the left-hand side of the screen shows the black vest. And then there's the carbon fiber rod that actually distributes the force of your, the neck, the force of your neck forward position. It distributes it basically along the whole spine down to your waist or pelvis. And then there's the headpiece on the right. And then that's me wearing it in the operating room. So this is like version number one of the vest. So I'm going to get my neck spine and just show the camera. I'll have to play around with the camera. I'm not a social media influencer, so I have no idea if I'm on the right angle, but so here's the headpiece. So um, these are the cables. It's the cables that really transfer the weight to your spine. And you can adjust the cable strength a small amount, like from lowest setting to highest setting. You notice it clinically, but according to the reps, it's only like a 1.5 Newton pounds or something like that. I forget the exact units of measurement, but it's a small difference between lowest and highest setting, but you certainly know it when it's cranked up. I use it almost cranked up. Some colleagues wear it and really crank it. So then there's also a fitting for a headlight. I never wear the headlight on it, but you can adapt any kind of headlight to the neck or to the headpiece. There's three different sizes of vest, three different rod sizes, and three different head piece size. And then this is the version number two of the vest. So this vest actually that I have now, it has a wider area of padding. One of the complaints, or many surgeons sort of had this complaint of in their mid back, the rod would actually push on your spine and be uncomfortable. So they really enhanced the padding on their version number two of the vest. So I'll just put it on. If we can, let me just try and adjust my camera. So it just goes on like a jacket, and then there's a Velcro waistband that just goes around my waist. So that's the vest part. And then the head piece just goes on. So then I just reach back to get the rod. I slide the attachment. I have like 3 finger bits, makes it pretty much horizontal to the ground. So then I just tighten it up. So that's what it takes that long to put on. So then you're basically gowned and gloved after you scrub. And the only thing I'd like to mention is make sure your nurse puts the Velcro of the gown underneath the carbon rod and not over top of it. Otherwise, it gets kind of tight in your neck. So I can sit down. One surgeon said, "Oh, I can't. Is it okay to sit?" And apparently, robotic surgeons have tried this, even in the robotic console. And I have a hard time understanding that. But sitting down on a stool, I almost have no cases where I can sit down, but I do also melanoma surgery. And say there's a melanoma in the forearm, I can use a arm table and sit at stools. So sitting at the stool, like I have very full range of motion. I can look either way. There's nothing really limiting my motion. Sitting down, standing, it doesn't really matter. So it's a comfortable device. Our hospital purchased 19 or 20 in 2 tranches. and this was before Dr. Hellbeck's study. But um, several surgeons, tried it, and I get these emails from surgeons saying, they couldn't do their job without it, and I'm basically the same. I wear it for absolutely every case. That uh, the thyroid surgery I was talking about with the operating microscope. I actually, it takes about 35 minutes to get to the phase where I bring in the operating microscope. So I wear it, and I could actually have the nurse detach the cable from the rod and just, using the operating microscope. I actually don't need the exoskeleton, but for every other case, pretty much I I use it. I use it routinely. It doesn't interfere with anything. There was a surgeon who tried it and he didn't like it, and he so there will be folks that don't like it. Some complaints, the vest can be a bit hot. I don't have that complaint, but you do wear that vest for a 2 hour, 3 hour case, and it perhaps I could see someone getting a little bit sweaty and hot from it. But uh, so that's my experience with it. I think it's really helps me. I couldn't imagine operating without it. So that's the neck spine. And then so before we get to the Q&A session, I just I just wanted 2 minutes to let you know about the Society of Surgical Ergonomics, and thanks again to the HFES for having us. But just a quick little history, and then we'll get to the Q&A on this webinar. Um, so the Society of Surgical Ergonomics is composed of surgeons and human factors engineers and nurses, and it's open to occupational and physical therapists. OR administrators even can join, trainees from any of those above areas, and then industry is also invited to participate in our society. There is global interest. It keeps forging ahead, farther and farther around, adding more countries. And just a quick timeline, it actually started by Dr. Geeta Lal in 2020 when she developed an ergonomics interest group on Twitter at the time. And then she invited a bunch of people to join, and we joined. And then somehow I said to her, we should create a surgical or a professional society. So we did that, and the nonprofit was formed back in June of 2021. And we've slowly grown and participated in other webinars and with ACS and SAGES. And then we've had an annual symposium since that time. So our fifth annual symposium will be in November of 2026. So it's been quite the ride. I was one of the founding members. I was the first treasurer of the SSE, and I'm very thankful to meet all these folks that we collaborate with. And it was basically a human factors surgical collision, and it's an area that I actually had no idea about. I am not a human factors expert, but because of my background with my neck pain, I got involved that way. Social media, we're growing. We're at 5,000 followers on X. I will have to say that Twitter was better than X, but we're still going strong. And then we actually have a booth at Sages, and then Dr. Lau and Dr. Hallbeck are measuring hand sizes for the hand study, the instrument and hand size study that is still in progress. So that's just a quick background of who we are at the Society of Surgical Ergonomics, and I will stop sharing my screen so that we can move on to the last session, the Q&A.
Thank you so much to all of our speakers. This was a phenomenal presentation. We do have some questions from the audience. Dave, do you want to kick off the first one as I share our screen with contact information?
Sure. So someone asks, what are some of the unique challenges as well as easy wins related to implementing interventions to improve ergonomics for surgeons? And then what about the rest of the care team that I think Jackie you hinted at with the others? So do you have some thoughts on implementing other kinds of interventions or easy wins for everyone?
Do you want me to start? So the challenge is getting into the operating room. It is a workplace. It is a very structured workplace. It's a very important and highly specialized workplace. And there's a lot of rules that govern it. Things like patient privacy, patient safety. There's a lot of limitations on what can be done in terms of going in there and just mucking about. So you have to be ready to go in there. You have to have only maybe one or two people in the operating room that are not on the surgical team. You can't have your entire team come in there. You can't talk in the operating room and chit chat, because then you're going to distract the surgical team, and their primary goal is to keep that patient safe and to get their job done. And so I think that there's a lot of things. And one of the things that Dr. Wooldridge, Abby, and I have put together is a list of the do's and don'ts. We intend to write that up soon. We've been saying that for a while now, but we do intend to do so. That would be helpful for somebody who wants to go in. An easy win for me was instituting something we call OR Stretch. And before we had a web app, which we now have, we went in there and led exercises with the surgeons and the surgical teams. And once I took basically the thorn out of the paw of the lion, then people were just telling me all sorts of things like, oh yeah, I had my elbow operated on the other day, and things like that. And it became then a relationship of how I could actually help them instead of I'm putting up with you in my OR. I actually helped them. And so that was a big win for me. Jackie?
I think it actually, echoing what you were talking about, like in terms of just getting into the room and talking with the folks, like I think once you build that relationship, like I think that's actually probably the hardest challenge, as well as like the most rewarding, as well as the eventual win. Because once people understand and see what you're trying to do, they're usually and often on board. And so it becomes, well, how do you actually build those connections, right? Like once you actually have that connection, how do you build it? Like I think a lot of the times, because we do add to their workload, right? So when we're actually saying, hey, we need you to wear this device, and for the work that Sue and I do, right? Like we actually have to have everybody hook up all the IMUs and the EMGs. We were talking about this the other day. We have to like actually shave them and actually like alcohol prep them, like the skin, so that we're actually getting good measurements. Like that takes time. And so I think it is, how do we actually inform everybody why we need to do this protocol that we need to, and then say and get them on board of like coming into the day an hour earlier, essentially almost, and then actually going through and then finding the findings that we do get from these. I think it was the more rewarding part too. Yep.
And we do try to use the first case of the day as our case, because then we can have things a little bit earlier and bring that the team in, or whoever our participant is, and make sure that we get that done instead of interrupting the flow. Because once they start and I'm going to pass off to Phil here, once you start your progression of patient, cleanup room, patient, cleanup room, patient, there isn't a lot of, I'm going to use the word patience, to interrupt that workflow. And not just from you, but from the team and from administrators, et cetera, because there have been some studies that have shown that it's like $110 a minute fully loaded for an operating room to run. So you have to think, is my 5 minute delay worth it? Phil?
Yeah, I mean, yeah, that I can go on for hours about turnover time, turnover time. So no one wants to increase that. So you got to clear the room out and get moving. Yeah, an OR room is very expensive, and I hear different numbers almost every week on the cost. The cost of running an operating room is very expensive. Um, but there's easily room to have researchers in. I could imagine being at the Mayo Clinic and having all this done, we don't do that much research in the operating room here at my place, but there's always room for it. You just need to, yeah, to get the IRB through and patient, HIPAA regulations and patient confidentiality and all that. I mean, I've done some videos in the operating room. It's not sort of research, but you just have to make sure there's nothing identifiable of the patient. They're covered, and don't even actually have the date anywhere. Date and time really shouldn't really be shown in the operating room either.
Okay, so thank you very much. There's another question here that is, given that we have both human factors and ergonomic professionals and surgeon on the panel, what's one thing you wish that other professionals knew in advance of interacting with as sort of your starting these projects or doing work in this area? Jackie, you sort of started to talk about that, but can you all elaborate a little bit more?
Yeah, I think I like my quick answer to that is it's getting buy-in from everyone. And I think, right, like some folks are, yes, like you're adding to the time and there's additional folks in the room, right? OR nurses are responsible for everybody in the room. And so when you have observers with tons of computers and different devices coming in, it does add to their workload as well. And so I do think the big thing is like we're here to help. But we're also here to systematically evaluate. We're trying to actually look at scientific research and help improve their workplace. So I think that's the large question or answer.
Yeah, from a surgeon's perspective and what I would want HF experts to know, it's just sort of just the problems in the operating room. And I think it's out there on what the issues are. I mean, there's just a list. There's so many issues. I mean, I can't tell you a worse design than the elbow-shaped operating room light. And I mean, I think I've herniated a disc just trying to position those elbow lights, and they get all messed up, and they get the lubrication starts to disappear, and it's like moving a 50-pound weight. And I mean, there's got to be a better design than the elbow light. So if an HF person knows that, for some reason they're all elbows, and I'm I'm telling you, I even have like a design in mind, like a half sphere, where you can just sort of direct a column. Anyway, Caltech or someone needs to get onto it, or you guys in HF. But so that's just one tiny example of what I would want an HF person to know. And obviously there's the instrument designed for small-handed people. Women tend to be smaller-handed than men, and there's a lot of problems with instrument design for a petite surgeon who can't fire a stapler properly. And that's I mean, that's a safety issue, and we haven't quite cracked it. It's so hard to crack that problem, but I mean, another example. So I could go on with all the problems in a noisy OR, the cognitive ergonomics in a noisy OR with suctions and alarms and maybe music, and so there's a lot of problems that you guys need to know about, and it's obviously there's folks that are onto the problems, but it's been, it's a great collaboration to work with Dr. Hallbeck, as a society member of the SSE and in her committee and prior, presidential work. I mean, like, it just opened up a whole new world to me, which at my level of career, anything new is so good. Give me the new stuff and to help some burnout, mild element of burnout. And this sort of avenue of HF, ergonomics, exoskeletons is fitting the bill to mitigate burnout.
I think y'all have said it. I think that the challenge is that we are going into somebody's workplace and not everybody is accepting as Phil is. mean, if every surgeon was like Phil and said, hey, come on in, I'll try anything. And I'd have some surgeon partners like that here. I mean, one person who is now retired said, sure. And he said, oh, so what did you want? And I was like, I still love you. Um, and I think that those are the kind of people that we start out with, but we want to spread it to even those people who are like, look, I just want to put my head down and get my work done. And those are the people who probably need the intervention more. And I think we need to think in terms of a little bit of the implementation science side of it also is how do we bring things in? How do we do some change management? And because typically in human factors, we've done these things and we said, here it is, but we haven't really done that piece to how does it impact the workflow as much as we could and we should because we're systems people. And then we need that same help from the surgical side in how to implement it.
Great. Phil, building on what you mentioned with the light above the surgical table, someone asked a question about the neck spine that you showed us. Is there a risk of that hitting the light or surrounding equipment? Because it looks like it is sort of high. So what are your experiences with that?
Yeah, so that's a that's a great question. Um, it does go above my head. So it has kind of hooked onto the handle of the light before, and it kind of jarred me for a second, but it was fine. Um, I don't think it hasn't hit the sterile cover of the light handle, but it could do that. It's hooked on the light before, but it seemed, other than a slight jarring, it was okay. I would, once every 2 months that happening, I'm okay with I'm okay with that.
And there's different lengths of that mast for different heights. You may be in between, Phil, because the ones that we fitted, it doesn't go much above the head. And so if your head would hit the light, then the mast would hit the light.
Yeah,
It's just
the
out a little bit behind your head, and that may be the issue.
yeah, well, so I measure 3 finger breadths is where I attach the headpiece to. So it's actually not, that's only like 5, 6 centimeters. So I
Yeah,
don't have much. That
no,
and
not
that
much
makes
of
the
enough flexion.
cable
Yeah.
that makes the cable horizontal to the ground. So I actually
Mhm.
don't have that much
It's
space.
not that much above your head because the cable is
Yeah.
along here. So
So
it's
and
not
look,
much
sometimes
above.
my head does hit the light handle, right? So yeah, this thing's gonna touch the light. And again, whoever asked the question, please design a new OR light without elbows for me.
Well, with somebody from your own system, from Kaiser Permanente, it was Sonia Paquette.
And then a cylindrical, huge not BTUs, huge lumens in a cylinder, and then it just moves on a sphere, on a half sphere, so you can get whatever angle you want. That's my design. How about it?
I think tying into that, we have a question regarding the exoskeletons used by surgeons. Are they considered a regulated medical device? And then if
They
so,
are not.
they are not.
So
Why?
I worked on this with Jack from NIOSH, and that they are considered a PPE. So they're not different than a chair. And that is how we sold that through our IRB. Is that how you did it too, Jackie?
Yep, and we say it's PPE and we're supporting the folks and we're not saying that it's a clinical trial either, right? We're not
That is also
evaluating.
true.
Yep. So
And we have gotten no pushback on that after I had the little note from him and then when NIOSH still existed. Um, and so that hasn't been a problem for us.
but I will note that exoskeletons for actual like patient scenarios and
Yes.
settings, right? Like the active exoskeletons for rehabilitation, for example, those are considered medical devices and are regulated by the FDA. But for the cases that we're sharing, it's not.
Yeah, this would be like these are passive, number one, as Jackie just said. And we're not putting them on patients, we're putting on the providers, and they can choose to don them or not.
Perhaps when we share all this information, Jackie and Sue, if you'd be willing to share some of like how you all got some of this implemented, or like that might be value added to other folks. And then I do want to go back to this question that someone asked early on. Given that this series is aimed especially at students and trainees, what would each panelist suggest to them if they are interested in a career in HFE and healthcare? And what about surgery specifically?
I guess you're waiting for me to start, Jackie.
I mean,
I think the best thing, I think the best thing is to try to get an internship at a medical center. And I know that we often have one, or with a faculty who is doing the work as for their graduate degree in hospital settings, in surgery, et cetera.
That's exactly what I was going to say. I was going to say a quick plug. I'm hiring graduate students. So the application deadline for medicine is not over yet. So if folks want to like look at this type of work, definitely I think because I do think the time to really learn, at least for me, was when I was in my study period, right? Like when I was a graduate student, I had to go to the operating rooms. I had to watch folks like Phil just like argue with the different type of lights, right? And so it is one of those things where I think that is almost like a protected learning time for students and trainees. That so I think having that extension, if you know that this is what you want to be doing, I think is very valuable. But I know that other folks don't want to or don't have bandwidth and things like that. But so definitely thinking about how can there be systems like internships or other careers in medical centers that are looking at this type of work.
Great. Okay, I have another question from the audience that says, isn't the flexion and extension of the arms directly influenced by the clinician's view of the patient and the immediate area surrounding the focal spot? When the visual access to the patient or target area is restricted, clinicians naturally adjust their upper limb posture to compensate. This creates an inherent dilemma, the need to maintain an optimal line of sight, that often forces clinicians into less than ideal arm positions and neck positions, increasing the risk of musculoskeletal strain. So, can you talk a little bit about that trade-off, that dilemma?
Sure. That is absolutely correct. You have to get to where you're doing the surgery. You have to get a good view of the surgical field. However, there are some things that can be done. If you're like tucking the arms of the patient or doing some things that allow you to get closer to that visual field, and I'm going to throw it off to Phil after that. I think that can make a lot of difference, maybe even tilting the bed a little bit to get a better view into the cavity that you're working in. I'm thinking about open, like solid organ kind of things. I think that there's a lot that can be done. And Phil, I think you probably know more than I do on this.
Yeah, so at the end of the day, we can sort of manipulate a few things, but not very much. And
Right.
at the end of the day, we have to assume the bad postures. So really, so I tell anesthesia controls the bed. I can't tell you how often raise the bed, raise it, lower it. And like a nipple sparing mastectomy has to be raised and lowered a bunch of times. And it might be just a few inches and back and forth and then tilt. Um, if a well-strapped patient, you can actually tilt more than you think. There have been cases of a patient sliding off an operating room table, so you do have to be very cognizant of that. But some good tilt can really help. But you always have to assume the bad postures, and that so the only way to mitigate that, I think, is micro breaks. Um, I do those every half an hour, 30 minutes, and I do it just for a minute and a half. But I mean, that's just part of my routine, and that helps a lot. Dr. Hallbeck's shown that, and it helps me. And so, but yeah, at some point we can't fix everything to be in the perfect ergonomic position.
And I think to echo that, like for folks that I've been working with in terms of like residents, so folks might not know, but when you have trainees who like, so Phil has trainees that are working with him. If there's somebody who's taller than Phil, they should set the table actually to the taller person. And so residents, there's that power dynamic where residents might not want to say, I need the chair, like the bed higher. So I think it's just informing folks that it should be set for the folks who are taller and then Phil using a step, for example. And just making sure that the coordination between everybody at the table doing that surgery is there when they are actually performing the tests.
Yeah, I agree.
Okay, maybe another a question here. What what do you think are some of the opportunities for non-PhD folks in this kind of work?
I'm going to throw that maybe back at Brittany for the human factors transforming healthcare, because there's a lot of opportunities for people probably with masters. I don't know about how many undergraduate degree human factors people. There's only like one program that I know of in the States that is that. But Brittany, what is that opportunity?
Yeah, absolutely. I'm happy to answer. I would say at the master's prepared level for folks specifically in the human factors field to be involved in a lot of this work. We have a lot of clinically embedded practitioners who don't have a PhD, um, who are doing phenomenal work. And really, I would say one of the most critical things to be clinically embedded is actually some of those soft skills or non-technical skills, your ability to connect with people and your ability to translate information all the way up to a CEO, all the way to the surgeon, to the safety folks, to the clinical engineering folks, to patient sitters. It's really the skills to be able to interact with anyone and everyone within the healthcare system um, that makes you incredibly successful. And also, I would say being embedded too is you're really happy with lots of things going on at once and kind of pivoting on a dime. If you're someone that really likes to be on one project and intimately know that project, and you like to really stick with it for a long time, clinically embedded is not for you. We like to joke around that we're jacks of all trade, masters of none. It's not unusual to be halfway down something and pivot to something else. So there's a lot of opportunity. Now, also, for a lot of our folks too, if you don't have any human factors training at all, you don't have a master's, you don't have a PhD, but you're really interested in this work, we absolutely, there's lots of opportunity for you to get involved too. One, connect within the folks within your organization, and then connect with folks on this webinar, connect, across and make these connections. A lot of work in healthcare is accomplished because of cross collaboration across multiple organizations and institutions. For example, the work that Dr. Cha is doing and the work from the simulation lab has seemed to be critically important to feed into Dr. Hallbeck's work, being able to like narrow it down for her to say, okay, thank you for doing this work in the sim setting. Now I know that I can narrow it down to these before I try and take this into the real like patient setting. So try and connect across different areas. But I would just say make the connections. Um, Collaborations are absolutely key, and that will help get you in and start to understand different areas that you be part of, but really make the connections, make the collaborations. There's work for all of us to around. You do not have to have like a PhD to be involved in some of this work.
So in the last just couple minutes that we have, I would like to pose to our panelist, what do you think is the future of work in this direction? What do you think the future of exoskeletons and other wearables in the OR looks like?
I
I
think
think
they're
there's
going
going
to
to be a
be
lot more of them. What do you think, Phil?
I think they're going to be ubiquitous at some point.
Yeah, I agree.
I don't know when, but I think it'll be routine and no one will look at you funny like, what the heck is that thing?
Yeah.
And I
And I think there's more and more acceptance of having aids in the OR. We're starting to call the gel mats that are under the feet, they're called princess pads. We call them smart mats. And I've been using that everywhere I go, and people are like, yeah, I guess I could call it that. And so I think just changing that culture a little bit, that you really want the career you want. That if you leave, it's not because you're in pain, it's because you're ready to go on your other opportunities. And I think there's going to be more and better designs for ORs. Hopefully, better lights, Phil. I'm with you on that. But moving things around on those booms is just really hard, and it gets in the wrong direction, and you have to unfurl it. Yeah, it's not easy.
think so. And I think on the engineering side, I do think that there is going to be a bigger development for these type of interventions in surgical settings. So the work then the exoskeletons that we've been all evaluating and looking at, well, I guess the next point not as much, but at least for the shoulder support, it's been developed for tasks in manufacturing. And so how can we actually have specific interventions or wearables for the surgical setting is, I think, a big boom that's going to happen.
And I also think that there's going to be some other interventions. There was one robot company, now there's a lot of robot companies coming in, and that's one other thing that could help with a number of these physical ergonomics issues. And I think testing those out and making sure that they actually do what they say they do is also important.
Great. So, I would like to thank Brittany and I would like to thank all of you for your presentations in the webinar today. This was fantastic, a lot of information, answered a lot of interesting questions. So we appreciate your time and effort today. This webinar will be posted on various places so that people can watch it later, including through HFES, Human Factors Transforming Healthcare group. And then we'll get that out so that it's on the Society for Surgical Ergonomics access as well. So we want to thank everyone for participating and all of the people for attending. Brittany, is there anything else you would want to add as we wrap up?
Just stay tuned for next year. We have so far, it seems like, received very positive feedback from this webinar series. So we will be back next year with more collaborations. And do please reach out if you have any questions. Really, we want these webinars to initiate new ideas and new opportunities for collaboration. Phil has set the stake down on the OR lights. I have to echo the OR lights. They need to be redesigned. So I see a future research project right there in the making. And that's what this is about, is really let's solve the real problems that our clinicians, healthcare workers, healthcare teammates are experiencing. Let's get human factors and ergonomics out even more into the healthcare environment and really show that we really can help improve our teammates' lives in healthcare and ultimately improve quality and safety for our patients. So thank you all, and for everyone that is here in the United States and that celebrates it, I do hope you have a wonderful Thanksgiving next week, and stay tuned for next year.
Thanks a lot.
Thank you.
Thank you.
Thanks.